Now coming to the etiology. Usually there are multiple causes and risk factors which may be associated with recurrent patellar dislocation or instability, but broadly they're actually divided into three different types. One is generalized and ligamentous factors, other is the bony or osseous factors, and third is actually the muscular factors. When we are discussing the generalized or ligamentous factors, the first and foremost and most commonly, it's always the generalized ligamentous laxity. Usually these people may have associated Ehlers-Danlos syndrome, they may have generalized ligamentous laxity. We need to go for Bitten scoring, especially whenever we have a patient with recurrent patellar dislocation. Bitten scoring is a part of our Bitten Horan scoring is actually the part of examination of the patella when we are checking for that. If the patient has chronic ligamentous laxity, that would mean that patient has natural tendencies actually because the ligaments are lax, his or her actually patella and other joints may also dislocate or subluxate as well. Therefore, any sort of a soft tissue procedure would not be really helpful. So we have to assess them in a different manner. For example, if their knee is also subluxating with patellar dislocation, then probably even a bony procedure will not be that much helpful. So you have to accept it as such sometimes. And if we are going for some form of surgery without realizing that we are actually doing this surgery in generalized ligamentous laxity patients, then surgery may fail completely and eventually patient may come up with again recurrent dislocation or dislocation of the whole of the knee joint as well. So all these factors has to be counted in, because this usually surgery in the case of generalized ligamental laxity usually has a very poor results. So all these factors have to be taken in account with detailed history as well as examination, and we have to do the Bitten scoring along with our examination in case of patient with recurrent patellar dislocation. Other factors which may be associated with called as ligamentous factors are actually the problem if the patient had an acute trauma, patient had an acute dislocation which happened probably quite a long time ago. This may have resulted in either the tear of the medial patellofemoral ligament or actually the medial constraints are actually tore. This results in increased patellar dislocation, and patient may eventually suffer from recurrent dislocation because the medial constraints and medial patellofemoral ligaments, it's not good enough that it can hold the patella medially, and rather as a result the patella subluxates laterally. One generalized factor includes miserable malalignment syndrome. It consists of three things. One is the increased femoral anteversion. There is genu-valgum, that is the distal part of the tibia is going outward, or we also call it as knock knees, and then external tibial torsion. External tibial torsion was present in our patient in a case study, but it can be isolated or it can be part of the miserable malalignment syndrome as well. That is why when we examined that patient, we looked at the feet. Are they both feet going out or not? What is the Q angle? Is the Q angle highly increased due to this miserable malalignment? And if that is the case, then probably you need to address all the three things. Addressing only the patellar constraints or the ligamentous abnormalities will not help as a result, because the problem is with the alignment, not with the ligaments at this time. Other factors actually include the osseous factors. Osseous factors, for example, could be related to or called as the bony factors, which may be related to there is a lateral femoral condyle hypoplasia or underdevelopment of the lateral femoral condyle and intercondylar groove flattening. This intercondylar groove flattening is termed as trochlear dysplasia. As this, if instead of groove being concave becomes convex or becomes flattens out, therefore it cannot actually restrain the patella in the groove. As a result, patella has increased tendency to subluxate laterally and eventually dislocate. Then other factors include, as I told you, maldevelopment of patella, which may be too high or too small. There is increased patella tilt. Patellar tilt means that actually the patella is tilted more laterally, and this tilt actually predisposes to patella to come out of the trochlear groove more easily. Or the patella may be too high, which is patella alta. This, or it could be too low. Usually too low does not dislocate, but having a too high patella or patella alta actually means that it predisposes the patella to increase patellar dislocation. Then, as I told you, valgus deformity of the knee could be isolated because this genu-valgum increases Q angle, or it could be part of the miserable malalignment syndrome in which there is increased femoral anteversion genu-valgum along with external tibial torsion. Then, as external tibial torsion could be isolated or part of the miserable malalignment syndrome, all these factors could be bony or general factors as well. Then there are certain muscular factors as well. For example, there could be a tear or defect in the medial patellofemoral ligament, or medial patellofemoral ligament may have ruptured or may be insufficient. As a result, it can hold the patella medially, or the dynamic constraint is actually the vastus medialis obliquus of the adductor magnus. This may also be deficient or may be weak as well. As a result, the increased tendency of patella to subluxate laterally during the quadriceps contraction. And this insufficiency may contribute to one of the muscular factors which may be leading to increased patellar dislocation or recurrent patellar instability.